Co-managing refractive or laser eye surgery patients, that's actually one of my favorite topics to speak about, and I teach about it at the universities because I'm a big fan of co-management, because often you as the optometrist will have a really long-standing relationship with the patient. You'll know them well, you know their habits, what they like, what they don't like, and that all feeds into their suitability. So you'll be better able to tell me than myself. I might meet them once, maybe meet them twice, whether they're suitable for laser eye surgery based on their expectations, their visual needs, their visual wants, or their eye health. And in the end, all that we both want, and the patient wants, we want them to be happy. And a happy patient is one that's ultimately suitable and has reasonable expectations of laser eye surgery. In terms of other things where I think optometrists can further help with co-management before laser eye surgery is particularly with regional or rural optometrists. Often you need to really screen these patients really carefully before they come for a suitability assessment, or sometimes even laser the same day. They have to travel a long way. They often have to bring their partner, often have to bring their family. So it's a big undertaking to come to Sydney, have laser eye surgery, and then turn around when you're told you're not suitable. So there's maybe two things which I particularly like to be screened for. One is whether the patient has a condition called Fuchs endothelial dystrophy. And with Fuchs, you know, when you look at it, unless you look specifically for Guttau or Fuchs, it can be quite subtle and easily missed. But as you know, it's a contraindication to laser eye surgery, and unfortunately that means patients will turn around and go home disappointed and not very happy at all. The second thing that I often request optometrists do is to measure the corneal thickness before surgery, because that can really forecast two things. One, it can forecast whether a patient is going to be more likely to have keratoconus and therefore be unsuitable. The other thing, if it's below 500 microns, is then you can more or less say that the patient is more likely to need ASLA or PRK rather than LASIK. And again, this needs to be said to the patient because it means more extra time off, and they need to factor that in. The other thing is they may not be suitable so much for surgery if they're more of a long-sighted or hyperopic patient. As you know, LASIK tends to do better with that than PRK. In terms of postoperative management, I'd say three things maybe. First and foremost is that good co-management is about communication. The lines of communication need to be open between myself, yourself and the patient. And so if there's ever any concerns between you, the patient, we need to communicate. And that way we can solve problems more quickly. And sometimes it can be an unfounded anxiety, which can be easily resolved without resorting to further sort of angst or worry from the patient's part. The second tip I like to give is that with patients, often they will heal at different rates after surgery. So, and you shouldn't be too hasty to actually say, well, this is the final refractive outcome, you might need an enhancement. Because often healing can take a while, and particularly with patients, they can appear overcorrected to begin with. So if they're myopic, they can appear hyperopic. If they've got astigmatism, the axis of their cylinder might actually be flipped. And so this is usually due to initially corneal edema, and as that settles down, then the patient will actually come good. The other thing which can masquerade as this is often dryness. So if the patient has untreated dryness, then they will also often have astigmatism which isn't really there, or appear to have under overcorrection. And I've seen some pretty amazing turnarounds in terms of vision and refraction once the patient is actually healed or you fixed their dryness. Just to talk about dryness further, dryness, as you all will know, is the most common reason for dissatisfaction or unhappy patient after refractive surgery. And one of the masquerades for dryness is actually preservative allergy. So if you have a patient where the dryness is actually lingering for far longer than you expect, then try switching them to preservative-free topical lubricants or topical steroids if they still need them, and send them away for 1 or 2 weeks. That's how long it takes for the preservative to leach out the system. 1 or 2 weeks later, come back and go, well, I'm so much happier now. So this year, for I think the 3rd year running, we'll be offering again our co-management program or teaching sessions with optometrists. And these are really good. They've actually been subscribed out each time because they offer a very small group teaching of refractive co-management. And it's actually one of the few times you actually get to see all three of us, Dr. Lawless, Dr. Sutton, myself, in one arena. And often there's only 8 to 10 of you. And then you can feel very free to ask any questions you'd like about refractive co-management. And so it's a really good opportunity to ask those questions that have always bothered you, but also get some more advanced teaching for refractive co-management. So if that's something you like to do or want to do, then yeah, you better sign up early.